What a distinct pleasure to be here. What a unique experience. Adam had prepared me for some music, but I didn't know it would be Gershwin. He prepared me for a tent, but I didn't know it would have chandeliers. Truly a remarkable convening. Let me start with just a quick introduction. I work with a firm called FSG. We're a nonprofit management consulting firm. We were originally founded by one of Harvard Business School's professors, Michael Porter, and he publishes with us a great deal as we think about the relationship between business and society. And the idea of shared value was originally put forth with Michael in the Harvard Business Review, and it was really exciting and generated a lot of feedback from various industries. But we found that since we are a nonprofit and we want the ideas to be implemented, that we actually had to go deeper and think about what does this look like for different industries. And so the first industry we looked at was the pharmaceutical and medical technology industries. And much of today's conversation will be based on that original Harvard Business Review article, as well as a follow-up article which was distributed in advance of today, Competing by Saving Lives. And a third article that we released last year on behalf of the United Nations Every Woman, Every Child initiative to look at shared value in maternal and child health, more specifically. So I'm not a scientist. I'm a management consultant trained in business and public policy, but I've worked with companies and organizations that relate to global health from many different dimensions. Certainly the pharmaceutical companies themselves, as well as large global funders like the Gates Foundation, some of the implementing organizations that are out around the world taking medicines and other interventions to the relevant populations. And today, we're obviously going to focus on the topic as it relates to companies, but I think, and since I'm told there's no chance to ask questions, I guess I can be as provocative as I'd like to be, but I think that the shared value orientation is a way to fundamentally change the trajectory of healthcare around the world, and perhaps save the pharmaceutical business model in the process. Andreas will have more to say about that following my comments. But we'll start with a story that brings some of these ideas to light. One of my clients was a nonprofit drug development organization, and they asked us to take a target product profile and test it in the field. So I found myself kind of trudging through the rural areas of Uttar Pradesh in northern India, and trying to figure out, if this thing worked, what should it do, and how would you actually commercialize it in this environment? It was intended to address the number one killer of children in India, diarrheal disease. So we started with mothers. What do mothers do when their kids get sick? What do they know about various treatments? So we would do these focus groups, and it turned out that mothers would assume, well, gosh, everything I put into this child is coming out the other end. I should just stop putting food in. And so the mothers would stop feeding their kids. Obviously, not what you would want them to do from a medical perspective. They didn't know about seeking care for this in different ways. So then we walked a little bit further, and we went to a local health provider, a quack in the Indian parlance. He'd been trained carrying the stretchers in the district hospital and had gone back to his village to open up a clinic. So we opened up the refrigerator and said, what is this guy offering his community? There's no aspirin. There were no antibiotics. This guy had third-line anti-malarial treatments, which from a public health perspective is a bit horrifying. And needless to say, did nothing for most of his patients and what they needed. We then went on and we talked to pharmacists. Pharmacists become one of those first places that parents go when they're seeking care, and we learned about the incentive payments that the pharmaceutical companies would give to those pharmacists, totally unregulated, that if they would push those drugs in the case of a child sick with diarrheal disease, then they would get a bonus. And of course, many of these drugs are poisonous to children. And all of this, I say, is that we could find a market entry strategy for this client. But it wasn't as simple as just getting a drug that would fulfill the dimensions of the target product profile. It was going to require understanding the rest of the dynamics in that health system in order for that drug to ever make a difference in the lives of these patients. And I think that is essentially what companies will confront as they consider shared value as part of their corporate strategies. So what is shared value? I should have asked for the, do the clicker. Perfect, thank you. So part of the reason that companies are thinking about this is because the role of business in society is changing greatly. You start with philanthropy. Many companies are very generous, appropriately so, donating to various causes, enabling their employees to go out and volunteer, and this is appreciated and appropriate, frequently not really all that relevant to their business strategy in many cases. Of course, corporate social responsibility is something that has come up more and more in the last 10 or 15 years, a lot of standards and reporting requirements that have come up. And CSR is essential, right? We need companies to comply with regulations. We need management of ethical behavior, and CSR provides a lot of the important frameworks for doing that. And certainly the kind of mini industry we have around sustainability appeals kind of from this corporate social responsibility perspective. I would suggest that shared value is a bit different from these, and not more important, but really complementary. It's part of this larger portfolio of approaches that companies use as they engage with society, because it's really about solving problems through core business activities. And as I go through these examples, you might think to yourself, oh, influencing health-seeking behavior, that's like a fancy word for marketing. Yes, that is the point, right? We want to think about the activities that companies typically undertake and how they can be targeted at solving social problems. So what is most exciting about this is, I think, the potential for scale. This is kind of the magic part of it. The magic comes from the fact that if we have an economic engine that reinforces activities that address social problems, then we have the possibility of addressing those problems at scale. Companies that donate their products don't get to scale. I work with a lot of nonprofits who are recipients of those donations who do tremendous work, but none of it is really ever at scale. So for me, part of what is so exciting here is the magic that can come from an economic engine that will propel social change. So briefly, kind of the concept of shared value, corporate behavior that enhances the competitiveness of the company. So not just the economic benefit, but competitiveness relative to peers. That advances the social and economic conditions of the communities in which those companies are operating. It's about creating economic value as well as societal value. And it's using capitalism. It is sort of, Michael Porter would argue, the next evolution of capitalism will be based on some of these ideas. So what is it not? It is not redistributing value, philanthropy, right, the value that has already been created. It's not the sort of personal values of corporate leadership, although many leaders in shared value do have corporate leaders very committed to the idea. And it's not a kind of responsive posture to noisy stakeholders and advocates. It's proactive. It's embedded in corporate strategy. It's completely unique to every company who has a different portfolio, a different approach to their work. And at the end of the day, it really challenges us to think about the fact that not all profit is necessarily equal. Profit from a shared value perspective is profit in the company's eyes, but it is social value for all of the other recipients of products and activities associated with that company. So it does have the potential, I think, to transform capitalism. To talk about shared value and the pharmaceutical space is almost so obvious as to be silly, right? These are products that are extending lives, improving the quality of lives, and generating tremendous economic benefit for many of the pharmaceutical companies. Deaths from cardiovascular disease fell about 30% between 1997 and 2007, due largely in part to new drugs that had been developed. Heart failure, down by 50% since 1995. There are endless statistics. You probably know many more of them. But it goes without saying that developing promising therapeutics has tremendous social value. I think that's pretty indisputable. The problem has become that the benefits of that value have largely resided in the developed world. So on the left side of this slide, you see the distribution of spending from the largest pharmaceutical companies, 3/4 of which in the US and in Europe. And on the right side, you see the percentage of deaths by case, by region. And here you can see the problem. What I think is promising from this, if you're looking at the right side, is that many, as we get more and more data about non-communicable diseases, we actually are finding larger portions of the portfolios of pharmaceutical companies that are quite relevant in many of the markets that they would like to enter. But this essentially, is part of the problem. When you think about the countries that are represented at the bottom of the left-hand graph, in India and Africa, 50% of the population doesn't have access to essential medicines. And essential medicines is actually a category of medicines, right, that the WHO puts forward as being the medicines that everyone needs to have access to. 80% of the world doesn't benefit from the sale of major medical devices. So diagnostics and treatment devices are simply not there. Now, these are not problems that are the fault of pharmaceutical companies, obviously. But when you layer on top of this the pandemic of AIDS and how AIDS has affected the behavior of pharmaceutical companies, I think we will all look back and see that this is what has started to influence pharmaceutical companies' behavior. And so the first response was really philanthropic, kind of going back to how the response is changing. $3.5 billion, committed in philanthropic spending, not limited to developing countries. Of course, the drug donations in places like the U.S. are over almost $6 billion. And these philanthropic programs take a number of flavors. There are certainly product donations embedded in these, broad-based capacity building efforts, other health systems-related investments. Some are product development partnerships, working with nonprofits to help de-risk some of the drug development. But despite this generosity, activists continue to respond to pharmaceutical companies by saying, this is not sustainable. So even the harshest critics don't see this as an answer. And as I say to some of my corporate clients, they don't always like to hear it, but philanthropy is not pixie dust. If someone does not like your business model, it doesn't matter how much you give away. At the end of the day, people are smart, information is available, and generosity is tremendous, but it's not enough to go to scale in addressing some of the problems. And there are major other trends that are influencing how companies are thinking about their business models. Certainly, fewer and fewer opportunities in high-income countries, given the cost of developing a new drug, the patent cliff, which is challenging income from existing products, and the sensitivity that many large payers have to the cost of medicines. Certainly, the potential that firms are seeing in middle-income and developing countries. I feel like we've been hearing about the growth that's going to come from these markets for about 10 years, and we're only now starting to see some of the innovation that reflects how companies will actually tap into these markets. But emerging markets expected to account for 75% of growth for the largest pharma companies, compared with a 2 or 4% growth rate in Europe and the US. And then the changing context around the global health response. There are tremendous gaps, as I said, in the health systems of most of the world's developing countries. But there's a recognition that the public sector is simply not going to be able to address that. Most of the healthcare in India, for example, is provided by the private sector. About 70% of spending on health in India is out of pocket. So there's a huge role for the private sector, not just in therapeutics, but in the actual delivery of care. And then you have increasing interest from the donor community, many of the big bilateral donors, as well as folks like the Gates Foundation, in wanting to partner with industry to think about new solutions. So shared value represents an opportunity to really transform health outcomes for the poor and earn revenue for the pharmaceutical companies. And we're starting to see some new models emerge, which is what I'd like to share with you. There's kind of 3 places where we see shared value taking hold. The first relates to products and markets. And in the pharmaceutical field, we think of this as R&D for new drugs. We think about this as the adaptation of existing drugs to reduce complexity or reduce cost, tailoring product offerings in a certain market to be appropriate for that market. That has to do with pricing, that has to do with packaging, the size of dosing. So there's a whole sort of realm of innovation that can happen around reconceiving products and markets. Second really comes into the value chain, and this starts upstream with what all of you know best, which is collaborative models for R&D. This reduces costs and risks. This may take the form of investments in new or existing research partners, academic relationships, investing in clusters where research happens to make it more efficient. Moving downstream, this also has to do a great deal with sales force and distribution channels, and then really locally adapting to supply chains and manufacturing opportunities in some of these countries. The third is around local cluster development, and this really has to do with that local healthcare environment in which those products are intended to be used. So this is where we go back to my example, and we think about things like behavior change campaigns, educating patients about the risks associated with different diseases that they've never heard of, health system strengthening, and that may take the form of improving infrastructure or training healthcare staff. And then there's a whole field in the cluster space that relates to advocacy and capacity building, regulatory protocols, and national guideline development. For many of these countries, they haven't had the advantage of large groups of people who have been advocating for this before, and there's a real role that companies can play in helping bring that about. I'll give you a few examples. The first comes from the medical technology field and GE's Healthy Imagination platform, which is a quite incredible effort from across this company. There was a goal set forward to invest $3 billion to develop 100 new products that would improve on cost, quality, and access targets by 15% each by 2015. A tremendous kind of challenge to the company and an internal group that was kind of coordinating this across the firm. There was a need, clearly, to grow their business in India. This is a common refrain, and they only had about 2% of that market at the time. So they thought about what was needed in India, and they developed this ECG machine. It's the most widely performed cardiac test in the developed world. They created a version highly portable, powered by a battery, can be carried to a patient's home. And when it was originally designed, it cost $800, compared with the version that GE sold to hospitals, which would be anywhere from $2,000 to $10,000. The engineers in Bangalore kind of kept working at it. They got the price eventually down to $500. This brought the cost of a screening test to the patients in rural India down to the cost of a bottle of water. Suddenly, cardiac monitoring is available to the rural poor in India. And there's a whole new version that's digitized and doesn't print everything out, so it saves on paper. And they continue to innovate around this machine and how it can deliver high quality but low cost services for these patients. More than 10,000 of these units have been sold, primarily through direct sales, and 90% of them go to individual physicians, folks that are not affiliated with large institutions, otherwise would have no ability to provide this kind of testing for their patients. It's a great example of adapting an existing product, really reducing the complexity and the cost associated with the test and making it available. Another example, probably closer to home for many of you, the partnership between GSK and Pfizer, which created Vive Healthcare, where they combined their two ARV portfolios. Both companies are owners of this new company. The margins and the revenues split kind of 85%, 15% based on the compounds that were originally contributed. But basically, both companies had small portfolios that were too risky. They were never going to live. But by combining them and moving them outside of the traditional pharma model, they were able to de-risk the investment associated. So they have a portfolio of about 10 established medicines. All the revenues from those go into the development of the 16 compounds that they currently have in the pipeline. And their strategy is really to provide a more consistent flow of HIV medicines with very focused R&D expertise just on ARVs, just on HIV patients. And they operate through a royalty-free licensing agreement. So this is going to be the low-margin, high-volume model that's needed to bring advances in ARV treatment to the millions who need it. And there aren't very many examples of this, really combining these portfolios in a way that's very separate. We have product development partnerships, which many of you might be familiar with, where the Gates Foundation, USAID, DFID, and others will kind of subsidize the cost of drug development. And at the end, if you get a product, then we get to sell it at cost, basically, in the developing world, and the rights to the traveler's market or the developed world will accrue to that original company. But besides that, this is an area where I think there's still a lot of room for innovation, and much of what you're doing, I assume, falls in this category. So the third example really relates to behavior change and more of the downstream innovations that are needed. So Novartis entered India in 2007 with a for-profit social business intending to serve but 750 million Indians at the bottom of the pyramid, so earning between $1 and $5 a day. There are 11 therapeutic areas included in this portfolio of nearly 80 products. Some of them are pharmaceutical products, some are branded generics, some are over-the-counter products. They treat everything from tuberculosis and diabetes to the common cold. And in order to be included in the portfolio of the products, you need to have packaging that is simple to understand by the target population. It's adapted to local conditions in terms of heat stability. And they need to come in very small packages so that people can afford to buy them with the incremental money that they're earning each day. So companies don't really know how to create these business models, and there's a lot of kind of skepticism. But this was given a 5-year runway to break even. They broke even in less than 3. The initiative currently covers 42 million people in 30,000 villages. Those are scale numbers if I've ever heard them. They're across 10 Indian states, and their goal is to more than double to 100 million people. Now, all the challenges that I mentioned in my experience running around Uttar Pradesh were present here for Novartis as well. So they had a very fragmented and not very responsive distribution channel. So they actually needed to cobble together their own network of very committed supply chain partners who could ensure there would not be stockouts of their products. In the rural areas, the infrastructure gap in terms of lack of clinics and lack of physicians was notable. So they would actually sponsor health camps where they would bring physicians out to these rural areas so that people could receive some of the care that they needed. Interestingly enough, that actually prompted many doctors to want to expand their business into these rural areas. People were still paying. But these doctors frequently didn't have capital to expand. So Novartis went into partnership with a microcredit organization to help bring the financing to actually develop some of that missing infrastructure, which was a great business opportunity for these doctors who are, of course, eager to expand. So a couple of interesting examples of how one company is starting to tackle some of those more complicated downstream issues. Their local sales team all speaks the local dialect, does a great deal of training out in the field. Obviously, none of this is limited to their products. All products on the market are sort of fair game. Many of these doctors could prescribe any of them. But they're now seeing additional opportunities to take advantage of this pipeline, this distribution channel that they've created. And we see this in other examples in global health, but suddenly if you've got a platform, who else's products can we put on there, right? Everyone faces this challenge of terrible fragmentation when it comes to reaching the peri-urban and rural areas in India. Well, these guys now have a platform that they can potentially leverage to competitors if they wanted to, or GE. GE's Embrace product is an infant warmer, and it faces similar distribution challenges, and they're in conversations with Novartis in terms of how they might leverage this downstream distribution channel. So it's fascinating, and this has been such a success for Novartis. They're now thinking about how can they replicate this in several African contexts. And to me, that is, crazy good news, because we've been waiting for some of this innovation to help reach some of these underserved markets in a way that is profitable, and it is profitable for them. So the question becomes, how much more exciting could this get? Well, it gets more exciting. If you do all 3 of these in one place, you actually see even greater momentum and leverage in these kinds of investments. There's a lot of mutually reinforcing benefits of investing at all three levels. So reconceiving products and markets, they're centered on patient needs. It's about improving affordability, but how are you going to improve affordability? It might be by redefining your value chain. It might be, upstream costs. So you're then looking at the upstream and downstream pieces of your business, who's then are required for leveraging some of the local expertise. Well, if you're going to look at local expertise, you're suddenly looking at that broader health context in which you're operating. And you start thinking about what are the interventions that might be needed to build that cluster and the supporting infrastructure that will ultimately make my products that much more profitable for me. The right combination of these things varies widely by company. I mean, it would be naive to think that every company has an opportunity to do this everywhere, kind of through all three of these prisms. But when companies step back and think about their core strategy through these perspectives, we think they will start finding these opportunities very relevant to their own positioning in the field, based on certainly the disease burden of certain populations, the portfolio with which they're working, their point in the market, the health system's strength of where they'd like to be operating, the cultural attitudes towards health. All of that will affect how an individual company will come at this. And it may not always be about serving the poorest of the poor. There will always be a role for philanthropy. It may be a very long time before the truly indigent will be, served through a market mechanism. But again, that will vary widely by company and by approach. So the last example I'll give you is Novo Nordisk and some of what they're doing in China. So the Chinese insulin market is about $1 billion market, and Novo has more than 60% share of that market. 92 million diabetics growing because of the aging population. About 70% are undiagnosed. So the size of this market is going to be going up. And only about 10% that are diagnosed are even successfully managing their conditions. Novo was one of the first Western companies to enter the Chinese market, and they did this very creatively in a number of ways, which I'll get into in just a minute. But part of what they measure is the social impact as well as these economic outputs. They estimate 140,000 patient lives saved from their work to date. Some companies do those calculations. More frequently, you see kind of cost savings calculations that are done. But when no one was receiving treatment in the first place, that becomes a harder case to make. And there's huge potential here, right? So when we think about these kind of three overlapping layers, what did Novo do? Suspense from the wind. So in terms of reconceiving products, they actually worked with Chinese technicians to adapt their insulin products to the Chinese market. Very intentional adaptation for the specific patient population. In terms of their value chain, they opened a local production facility, which actually was able, in an R&D center, which allowed them to attract some of the earliest, highest quality talent in China as well. They were the first non-Chinese company to establish an R&D center in China, and the first local production facility in 1995. And then they undertook a broad set of activities related to the cluster and strengthening that cluster. One was through the World Diabetes Foundation, which they are a major funder of, but through that foundation and working with the Chinese government to develop the national standard treatment guidelines. They worked with a tremendous number of physicians on physician training on those guidelines and on the different products on the market. And then an awareness campaign. Again, patients didn't necessarily know that this was a problem that they could be faced with. So a huge awareness campaign, both among the physician community as well as patients. And what I think is so interesting is the measurement piece, and I'll talk more about that in a minute, but extending good disease management to all of the urban areas could literally be worth about $37 billion to Chinese society and about $30 billion to Novo. I mean, those staggering numbers, again, sort of the scale that we were never able to find in a kind of CSR orientation or a philanthropic orientation. And about a week ago, we had 6 or 7 of the big pharma companies in our office in Boston, and we were talking about this big measurement challenge. And as the guy from Novo said, well, the next big thing after China is China, because it just keeps getting bigger, and nothing is going to come close to the scale that we're going to see in terms of the needs in China. And again, what they've learned through this effort has them very optimistic for a similar model in Nigeria, in India, some of these other big markets that remain terribly underserved. So I'll close by just talking a little bit about what this might mean for implementing shared value in companies. Certainly, like any management idea, the prescription that leadership be on board is probably pretty predictable. Leadership doesn't have to be on board. We've worked with a lot of companies where shared value is kind of one piece of one business strategy and needs to prove the case and then becomes maybe more adapted through the rest of the company. But certainly, like anything in business, if the CEO is on board, it's a lot easier. Andrew Whitty from GSK is a great example of this. One of the innovations that I'm always most impressed by was their decision to change the compensation model at GSK in Africa so that the sales force was no longer compensated on the value of the products they sold, but they were compensated on the volume. And overnight, you go from a high margin, low volume business to a large volume, low margin business, and you improve the access to those medicines for millions of patients. So having CEO involvement is sort of a layup. It's an obvious one. The culture of innovation and learning, again, feels sort of strange to say you would need this in a pharmaceutical company. I mean, it's all about innovation. It's all about learning. But truly, it's about learning and experimentation with business models. And there's a level of patience required in that I think is harder to find in any company, and certainly for the pharma companies that I've worked with. Medtronic is another one, Novartis, where they are experimenting. Medtronic has this great example. They make pacemakers and complicated cardiovascular and diabetes products, and they would like to enter these markets as well. But they're sort of asking themselves, how do you integrate cardiovascular care into the primary health system? I mean, you're barely getting people diagnosed for malaria. How are we going to get them to sort of need a pacemaker? So they're using their philanthropic funding in Rwanda through Partners in Health to fund experiments. In fact, my mother-in-law's sister just went to Rwanda as part of a cancer program out of the Dana-Farber Institute in Boston to help teach people within the Partners in Health program how you can sort of simplify some of the care associated. This is a way for Medtronic to learn about this market, to learn about primary health care in some of these rural, developing world settings. But that takes a really targeted investment and an open management team to believe that the learnings from that can come back. I mentioned the topic of measurement, and in fact, all these companies were in Boston with us last week because this is so hard. Everyone's sort of saying, really, I need to measure the impact on this disease in this population, or can I just measure access? Well, it sort of depends on your objective. If you're a company who sees yourself as only making medicines, then that's limited measurement might be enough. If you see yourself as a company that's about delivering health, then you're probably making more of those context-setting investments, and you really want to measure those as well. Importantly, if shared value is working, then the success on the social side is driving success on the business side. So you can't actually measure them separately. You have to measure the connection between them, and it's very complicated. And we've got another whole paper on sort of what we're thinking so far on measurement, which I'm happy to make available. The whole idea of new skills associated with identifying unmet health needs is sort of a different orientation. It's not about like, here's our portfolio, what could we do with it? It's about, here's the market we want to serve, what are their health needs, how can we serve them? And it's, kind of the collision of those two dimensions of business coming together. But businesses really need these skills in terms of figuring out what those unmet health needs are and how are they embedded in those systems and how can those systems be improved. Many of those skills just don't sit right now in pharma companies. At Becton Dickinson, they actually changed the country leader job description to not just be about the P&L at the country level, but to emphasize the knowledge of local health needs. And this was the new embedded expectation for the country leaders in the business. And so finally, this point about new partnerships. This is easier to talk to for kind of a pharma crowd than for the NGO crowd. But I think the kinds of partnerships that will be needed both upstream in the R&D field as well as downstream in these health systems is really going to challenge kind of the conventional relationships that we've seen between industry and the nonprofit partners that it would typically be a part of. So since there are no time for questions, I'll just leave you with the idea that I think this is just the beginning of this. We've got a couple of these examples. We've written up what we've seen in some of the papers that have been shared. But I think it's through our continued work, we're doing work with Lilly and with Novartis and with Merck, thinking about their market entry strategies. But I think we will continue to push on some of these market failures. And I feel very optimistic that these business models and the innovation in the business model will actually challenge the frontier we're kind of bumping up against when it comes to shared value, such that eventually, I think if it is working, we will change the way health is delivered.